Good morning, guys. We're going to talk about use of intentions wave-free radio or fractional flow reserve in PCI. My name is Cristian Rosas Borja. I'm from Universidad Católica de Santiago de Guayaquil for psychomedicine. There is my social networks. Follow me. Definition. The instantaneous wave-free radio is a diagnostic tool used to assess whether a stenosis is causing a blood flow in coronary arteries with subsystem ischemia. There's a video.
So two other trials of importance were presented at the same time we did Absorb at the late-breaking clinical trials at ACC, and they both had to do with IFR. As background, FFR, fractional flow reserve, has now been studied fairly carefully and has been shown to be a much better marker than angiographic percent stenosis, or the operator's impression of how severe a lesion is. So if the FFR, for instance, is greater than 0.8, in general, those lesions should indeed be left behind. So why am I talking about FFR when the topic was IFR? FFR is a little bit complicated or a little bit messy to use in the lab because you have to mix adenosine, which unfortunately is kind of pricey. And I think it's to a certain extent inhibited the use of FFR in the lab. And I believe 20 or 25% of patients undergoing PCI in the United States now have FFR. So what IFR, the difference is you still have to pass the lesion with a wire, but you don't have to use a vasoactive agent such as adenosine to vasodilate. So it makes it a little easier. And the bottom line is IFR with a cutoff of 0.89 is just as good as FFR with a cutoff of 0.8 in terms of deciding which lesions need to be treated. So hopefully this will lead to an uptake of physiologic assessment of lesions in the cath lab, which again has been already shown to be better than angiographic assessment of lesions. So it should be a win for both the patient and the physician in the cath lab.
Application in medicine. A total of 2013 participants with severe or acute coronary syndrome who had an indication of psychologically guided assessment of coronary artery stenosis were randomly assigned to underground revascularization, guided by either EFR or FFR. The primary endpoint was the rate of a composite of death from any cause, non-fatal myocardial infarction, or unplanned revascularization within 12 months after depression. There is a video.
Fractional flow reserve, or FFR, is defined as the fraction of maximum achievable blood flow that can still be maintained to the myocardium despite the presence of a stenosis. During maximum hyperemia, FFR can, through a series of simplifications, be calculated as distal pressure, PD, divided by proximal pressure, PA. Let's look at an example. PA is measured via the cath lab's standard AO transducer, here 100 millimeter mercury. PD is measured by the pressure wire sensor, located distal to the narrowing, here 70 millimeter mercury. 70 divided by 100 gives an FFR of 0.70, which means that only 70% of the maximum achievable blood flow is reaching the myocardium. Sensitivity and specificity of using a threshold value of FFR less than 0.75 for detection of reversible ischemia has been shown to be 88% and 100% respectively. This means that when FFR is above 0.75, you can be quite certain that the lesion is not the cause of ischemia. The risk of deferring treatment of a significant lesion is small. It also means that when FFR is below 0.75, treatment is always justified, if technically feasible. FFR is a strong predictor for long-term outcome after an intervention. In this example, the post-stent FFR was 0.98, which is very close to maximum myocardial perfusion and a very good stent result.
Pros and cons. Alternative FFR computation systems have been proposed, for example, incorporating part of systole into definition of diastole, and optionally different time shifts between PD and PA signals, yielding unsatisfactory results. The same database reanalyzed using the standard algorithms confirmed the mainstream findings. There is another video.
Has certain benefits over FFR. FFR uses a vasodilator such as adenosine in order to increase the coronary flow in order to measure accurately. The downside of using adenosine is, of course, the side effects and the costs associated with that. IFR, instantaneous wave free ratio, is a resting gradient where they look at the diastolic blood flow. So there are certain benefits such as cost, less discomfort for the patient using IF trials that looked at ischemia and found that IFR is all those cases equally good, and in 2 cases actually better than FFR when it comes to detecting ischemia. So there's quite a
application in echo. Non-invasive tests can include stress testing such as exercise electrocardiogram, stress echocardiography, and perfusion imaging tests such as scintigraphy or SPECT. Alternatively, invasive tests may be performed at the time of angiography, and these include those that measure coronary flow velocity in the vessel, CFR, or any flow gains pressure gradients such as euparotemic or basal stenosis resistance.
Would you see this data affecting the status quo now? Like, what's would you expect people would start using more IFR versus FFR?
Well, I think define flare, 2,500 patients, a clinical population of which we're actually practicing using these tools. As big as all the physiology studies put together, but it's the first study which looked identical results.
Same results, right?
Exactly, identical results. So I think there's huge power here to change guidelines. We've already seen the appropriate use criteria being updated now to include IFR. I would expect that there's probably evidence now probably to help both FFR and IFR get higher in the US guidelines, and I fully expect that the European and Japanese guidelines will change accordingly to include IFR with FFR on the 1A classifications, as you've seen the appropriate use criteria guidelines be modified accordingly. I think ultimately, and kind of a take-home message would be that, whether physicians use IFR or FFR, that's their own choice. This gives more choice to people, and we have the greatest body of safety data out there to support it. But I think the real benefits for patients are seen if people are doing more physiology.
Right.
So the results show that it's basically the same, whatever you do. Obviously with IFR it's potentially easier to do and nicer for patients, but there's similar results. And if we can get more people using physiology, that's going to benefit more patients. And that's much more important than moving a few people who are doing FFR to IFR. Yeah, so you've got to get more people using physiology, improve outcomes, more appropriate stenting, and hopefully mean that people have longer term better qualities of life free from angina.
Sounds good.
Conclusion. Cardiologist uses a combination of this investigation together with the patient history, symptoms, and clinical risk factors to decide if stenosis requires further treatment.